Hello everybody, I'm Dr. Panacea. I'm the Chief of Anesthesia of the Cardiovascular and Thoracic Department of the University Hospital in Catania. An episode, I think it was 12 years ago, impressed me a lot. A woman, the day after the operation, told me that she didn't feel any pain during the night. She was very comfortable, but she could tell me everything happened in the operatory room. She was able to repeat me everything I said to the nurse and every dialogue I had with the surgeon. And that was for me terrible, really terrible. And I was convinced I have to adopt something in my operatory room to avoid awareness. And since I've been using entropy, I have ever had any awareness in my operatory rooms. The other thing is that I was convinced that when the patient's arousal from anesthesia, too many times people told me about diplopia. So I tried to have something that could tell me how my patient was in terms of coagulation during the operation, at the end of the operation. I found that craniomyography was the best way to respond to my needs, because you don't have to use another device. You are all incorporated in one monitor. For the nurse, it's very easy to use it. The most important things I could learn with the use of NMT is that every neuromuscular blocking agent metabolized in a different way in different patients. So, too many times I look at the patient's breathing and moving his arm, but it was on 3 response on 10 or 4. Does it mean that the clinical signs are not able to make us know where the patient is in terms of depth of neuromuscular block? If you don't measure, you don't know if your patient is on post-residual coagulation. The other thing is that we use a lot of peripheral block. We combine it with a general anesthesia in a balanced way. And for us it's very important to know if the block has got a full coverage of our analgesic stimuli. And using a system like surgical plethysmographic index permits us to know exactly where the patient is. We have to add also very little quantity of opioid, of remifentanil, for example, because a part of the body is not fully recovered by our block.
So for us, SPI is a great parameter to be sure our patient don't feel pain.
Of course, there are some tips and tricks, like vasoactive drug or vasoconstrictor, because maybe it can give you a false number. The last thing is that I think you have to look at the trend more than a single value. So, the most things we can monitorize, the best you can treat your patients. I suggest everybody to have a system in your operatory rooms that permit you to have a clear idea of if your anesthetic plane is the right plane, and if where you have been able to choose the right anesthetic agent for your patients, and to know if your patient is in a deep neuromuscular blockade and if your patient is going to feel pain. It's of great importance for us to know everything. So I suggest everybody to use something like this in your operatory room.